Hi class, it's Amy. I'm presenting my case study on acute pancreatitis today. So as an overview, we'll be going through the nutrition assessment, then the diagnosis, intervention, and then finally monitoring and evaluation. So first is nutrition assessment. The patient. So we have JM. He's a 29-year-old male, Caucasian, single person. He only speaks English. He has 16 plus years of education. He is a full-time PhD English student. His religion is Jewish. He has no known allergies, and he's in MICU bed 5. For his medical history, he had an appendectomy at 12. He takes no medications at home. He has a history of depression, and he has a history of alcoholism. He drinks a 6-pack of beer a day. He takes 4 to 5 shots of bourbon daily, and then on weekends he also drinks wine and other mixed drinks. He has no history of tobacco use, and his family history includes breast cancer from his mother and hypertension from his father. He has no history or notation of physical activity. The reason for his admit to the hospital was that he was suffering from nausea, vomiting, and acute abdominal pain, which he thought was something viral going on for the past several days. But he presented to the ED 48 hours ago when his neighbor/friend brought him, and it looks like they sent him home in the case, and then he returned because of the increasing pain and then was admitted to the MICU. His active diagnosis is acute pancreatitis, most likely related to his chronic alcohol intake. I compiled the notes from the case study to make up his biochemical data, medical tests, and procedures. His temperature, pulse, respiratory rate, and blood pressure were all high, probably from his state of stress. He's 5'11", he weighs 245 pounds at admit. He's alert and oriented. His skin is clammy. He has rapid but clear respirations and diminished bilateral pulses. His nursing assessment revealed an obese, tense abdomen, hypoactive bowel sounds, probably from constipation, cloudy amber urine. His skin is pale, warm, dry, and tenting. He has a dry nose and throat, and his Braden score is greater than 18, which indicates no risk of developing a pressure ulcer. Complete blood count, comprehensive metabolic panel, amylase, lipase, and magnesium labs were ordered. In addition, radiology will conduct an abdominal series, a CT of the abdomen and pelvis, an abdominal ultrasound, and vital signs should be taken every 4 hours. An intake and output record should be recorded every 8 hours. NG tube should be placed if there's persistent vomiting, obstruction, or a severe ileus. An NPO diet is suggested along with bed rest and IV fluids. The MD progress note on day 2 revealed that temperature and respiration rate were still high. The patient is still alert and oriented, still acute abdominal pain. An Apache score of 4 indicates a low mortality prognosis. There's still hypoactive bowel sounds, abdominal tenderness with rebounding, guarding, nausea, and vomiting. The MD assessed the abdominal images and sees elevated lipase, amylase, and CRP labs, which you'll see on the next slide. So his diagnosis is acute pancreatitis, and this is when the RD is consulted for nutrition support recommendations. So these are the results of the patient's labs. The high BUN and creatine levels indicate low kidney function or dehydration. The high glucose indicates impaired pancreatic function and low insulin levels. The high bilirubin indicates that the inflammation is impairing the bile duct, which is affecting liver function. The low albumin indicates liver disease or inflammation. Same with the ALP and SLT and alkaline phosphate, all indicating liver disease. The high CPK indicates injury or stress. High LDH indicates tissue damage and organ failure. The lipase, amylase, and CRP levels are indicative of acute pancreatitis or pancreatic problems. High cholesterol and triglycerides are persistent with organ failure, and the increased white blood cells, neutrophils, segs, and bands indicate infection, and high protein and ketones indicate ketoacidosis from the stress of the patient. And then again, the high bilirubin and urobilinogen indicate impaired liver function. These are the patient's current medications. The first is imipidine, which is an antibiotic for the pancreatic infection. Next is Pepcid, which is an antihistamine and antacid for the indigestion with the nausea and vomiting of the patient. Next we have Meperidine, which is a narcotic for pain. Then we have ondansetron, which is for nausea and vomiting prevention. We have Colace, which is a stool softener since the patient's constipated. We have milk of magnesia, which is a laxative and antacid. And lastly, Ativan, which is for anxiety. So as far as food and nutrition related history, the patient's usual intake is coffee with a bagel or toast for breakfast. He has a sub, sandwich, or pizza for lunch, and he normally eats out for dinner. He again has a six-pack a day with 4 to 5 shots of bourbon, and then on weekends he has wine and other mixed drinks. In his nutrition note, it stated that the patient didn't realize how much alcohol he has been drinking since he's been trying to stop taking his antidepressant medications. He states that he's gained 50 pounds over the past 5 years, and since his onset of symptoms, he has eaten very little over the past 3 days because of the nausea, vomiting, and abdominal pain. He lives with a roommate and he can prepare food and feed himself. It didn't say on his case who does the shopping and cooking, but he's definitely able. And his current nutrition order is NPO, which is inadequate intake, and he is not taking any supplements. So the patient's anthropometrics, he is 5'11", he weighs 245 pounds. His ideal body weight is 172 pounds. He's at 142% ideal body weight. His adjusted body weight would be 190. His BMI is 34.2, which is obese class 1. His usual body weight when he was 50 pounds lighter 5 years ago was 195. He's at 126% usual body weight, and his admit body weight hasn't changed from the 245. As far as his needs, I used adjusted body weight since his BMI is over 30 and his ideal body weight is over 130%. His kcal needs are 2150 to 2580 kcals per day. I use this range because the suggested range for enteral nutrition in acute pancreatitis is 25 to 35 kcals per kilogram, and I chose 25 to 30 kcals per kilogram because when I compared it with Mifflin St. Jour with a 1.0 activity factor since he's bedridden and 1.3 injury factor since he has an infection, that was at about 2400 kcals, which is right in that range. And then his protein needs are 100 to 130 grams per day, which is again the suggested range for enteral nutrition in acute pancreatitis, that 1.2 to 1.5 grams per kilogram. And then for fluid needs, I did 1 milliliter per kcal or per MD because fluid resuscitation may be part of the treatment plan. And now on to nutrition diagnosis. The PES statements I chose that I think would best suit this patient are inadequate energy intake related to decreased ability to consume sufficient energy as evidenced by nausea, vomiting, and NPO status. And the second is excessive alcohol intake related to stopping antidepressant medications as evidenced by intake of 6-pack of beer, 4 to 5 shots of bourbon daily, and wine and other mixed drinks on weekends. And his nutrition impression is high risk. Next is our nutrition intervention. My first recommendation is to initiate a nasojejunal nutrition support of Vital AF 1.2 cal at 20 milliliters per hour and advance 10 milliliters every 4 to 6 hours until the goal rate of 85 milliliters per hour with 140 milliliter flushes every 4 hours is reached. And the goal rate provides 2,400 kcals per day, 150 grams of protein per day, and 2,400 milliliters of fluid per day, which is 100% of the patient's needs. I chose a NJ tube over an NG tube because they provide greater pancreatic rest, and post-pyloric placement of nasoenteric tubes are used for patients with gastric complications. And then I chose Vital AF 1.2 cal because it's a therapeutic nutrition designed to promote tolerance for those with impaired GI function. It uses hydrolyzed peptide-based proteins and structured lipids from MCT/canola oil, and also Nutriflora prebiotic fibers. The other ingredients are EPA and DHA, which are from refined fish oils, and they are an additional benefit to managing inflammation and supporting immune function. I will also monitor EN feeding rate progression, counsel the patient on appropriate alcohol intake, consult a social worker to guide the patient in treating alcoholism, monitor the patient's ability to begin PO intake, monitor lights and labs, and assess daily weights. I will implement this intervention through education on tube feeding and appropriate alcohol consumption. There's no barriers to the patient's learning. The patient himself is being educated. He has a good status of understanding. I'll use a handout on tube feeding and a handout on appropriate alcohol consumption to educate, and the expected outcome is good. I will follow up with the patient in 1 to 3 days. His discharge plan is to reintroduce PO intake, starting with clear liquids and then to continue with solid food as tolerated. Oral supplements and/or EN support will continue at discharge if PO intake is still inadequate, and the social worker will assist the patient in finding appropriate resources to treat alcoholism. And lastly, we'll talk about nutrition monitoring and evaluation. So the patient's first goal is that they will receive 80% of their recommended kcals and protein via enteral nutrition during hospitalization. We'll determine this via documentation of provision of enteral nutrition or by the RN report. So far, they've had 0% of their tube feed provided since the order was just put in. The NJ tube will begin today, again to meet 100% of their energy needs with Vital AF at 85 milliliters per hour with 140 milliliter flushes every 4 hours. And then the second goal is that the patient will understand the nutrition topics, and we'll monitor this through the patient giving an affirmative answer when asked about the understanding of the topics. They did express an understanding of tube feeding and appropriate alcohol consumption. They're working towards their goal, and again, I will follow up with the social worker to make a discharge plan for treating alcoholism. Thank you very much for listening.